Good afternoon. Thank you for having me here to discuss the most recent update on COVID-19 as of this month for October 21. This virus, which we start to know since December of 2019, becoming a well-known virus to all of us, but the disease is really complicated. And I would like to simplify this illness into stages. Stage 1, in which there's early infection, is when the patient become infected with this virus. There's viral replication in the upper respiratory infection, in the upper respiratory airways, and then maybe in the GI tract. Stage 2, when there's pulmonary stage, and stage 3, which is there's inflammatory stages, and then there's stage 4, which is multi-organ failure stage. So this illness of COVID-19, it should be looked into a very complicated disease, more like cancer. It's not like a simple inflammatory viral illness, upper respiratory illness. It's really complicated. And the problem is, since we don't know, we don't have a viral culture, so we're really guessing at this stage. Even though we came a long way since the beginning of this disease, we have now PCR testing, and we have inflammatory markers, and we have chest X-ray and CT scans, etc. But still, it's a very complicated disease. Initially, we thought it was a primarily respiratory viral illness, but it's really clearly now it's multi-organ disease with multi stages, and affect certain individual with a specific HLA have a really bad outcome, and while the majority of the patients people do well, but we have 3 in 1,000 who have really high mortality rate, and they certainly will die from it. We don't understand completely the pathophysiology, but we know there's hypercoagulable state, we know there's pulmonary destructions, we know there's endothelial destructions, and we know there's multi-organ disease. COVID-19 is recognized now as a complex, multi-organ, and heterogeneous illness, more than just an upper respiratory infection. Patient with COVID-19 have multiple symptoms, as we all know it by now, from loss of taste, upper respiratory infection, upper respiratory symptoms, to GI, to neuro, to thromboembolic phenomena, neuropsychiatric illness, and now we know there's post-COVID or long COVID disease. And obviously we have some patients who unfortunately they will die from this illness regardless of what we do. So it's really a complex and complicated illness, and we should look at it in stages. In the first stage, where there's a viral application and there's no hypoxia and there's no lung damage, we can use antiviral, we can use monoclonal antibody. Once there is a lung damage, once we have hypoxia, then we can use steroids, remdesivir if available. And then if there's high inflammatory markers and severe hypoxia, we can try to use baricitinib or tocilizumab in specific patients. Obviously, we don't use convalescent plasma. It doesn't work anymore. In the beginning, we tried it. It doesn't work. There's other medication which we all tried in the beginning, and it doesn't work. At the present time, I would like to simplify the disease in stage 1, in which the patient is not hypoxic. They begin with, in the beginning, in a few days, if we're looking at virus alpha, in which is 2 days to 3 days. Patient is asymptomatic, but they're highly infectious. In delta, the patient is highly infectious for 4 days, and that 1 to 2 days difference made alpha is a lot easier or less infectious than delta, and that's why we have this third wave in our community. Children and younger adults are more likely to be in this group, which is asymptomatic, but they can still progress, and that's why we're looking into vaccinating the younger population, and there's studies going on at age 5 and up, and I think the vaccine will be approved for this group in early November for age 5 and up. Because we really don't have a good treatment, but the vaccine is highly efficacious, as we can see and we'll discuss, especially for all these new mutations, including Delta and Mu, and all the hopefully the next few variants which we're going to see. The virus, which is highly infectious in the beginning when the patient is asymptomatic, and that's why this disease is very contagious, and everyone, in my opinion, is going to either have immunity by the vaccine or by the virus. There's really no way around it, and that's why we think in the next year or so we either vaccinate the whole world or the whole world will get the disease, unfortunately, and then in theory we can get rid of this virus. We did a testing with the immunoglobulin and to see the widespread of the disease, and back in December of last year we thought there was about 30% of the population already have the virus. The problem with the Delta variant that is because it became more infectious, 1 to 3 versus Alpha variant, which is 1 to 2. We had to go up from 50% to 78%, and that's why we had a higher or a third wave in this disease. Once we get a 60% to 70% of the population immune, then we can start to see a decrease. And I think since we have vaccinations at 60% as of today in the United States, and we probably have a little bit more infectious rate, I think we are at a plateau. Unfortunately, the plateau will be higher in states where there's not enough vaccinations than states which are more vaccinations. And in Europe, unfortunately, they are vaccinating more than us, so their rate is less or better than the United States, even though we start to have the vaccine before them. During the early infection phase, in phase 1, the virus multiply inside the body and the blood, and that's where there's viremia. The symptoms usually mild. The symptoms are upper respiratory infection, and that's why it's the patient is very infectious in this stage. Now, when the patient is vaccinated, their symptom is more like flu-like illness, and so whenever we have an epidemic or endemic of COVID in the community where we still have high circulation, anyone with flu-like illness, we have to assume they have COVID at that time. One of the interesting findings which we found and we learned in this disease, that high viral load, measuring the viral load in the secretions and the blood, these patients are at high risk to having more serious illness, and they're at high risk of having higher infection. So that's why we had really unfortunate cases in the beginning in which physicians and doctors and healthcare employees who were exposed to high viral load, they have higher mortality rate. And this is independent of other factors such as obesity, diabetes, high blood pressure, COPD, congestive heart failure, renal disease, or any immunocompromised disease. And these patients with high viral load they end up with a poor prognosis. So that's why even if the patient is vaccinated, even if they have previous COVID, if they're still in the community where there's high circulation of the virus, we tell them to wear masks, to be cautious, and to avoid social distance and to respect social distance. Post exposure prophylaxis with monoclonal antibody or early stage of illness, monoclonal antibody is extremely efficient. It reduces mortality rate by 50%. So people who have a high risk for COVID-19, people who are exposed to COVID-19, if we can see them and seek them and give them monoclonal antibody, which is the only drug which really approved and it does really work, giving them early before they became short of breath, before they had pneumonia, before they end up on a ventilator, these patients do very well. And that's why as a primary care physician, if we see patients who have a proven COVID-19 or have proven exposure to COVID-19 before they become short of breath, we should give them the monoclonal antibody, especially in high risk factors, and we'll discuss these patients in a minute. Even if they were vaccinated, it doesn't really matter. If they are vaccinated and if they're at risk, we should give them the monoclonal antibody. So who are the patients who get the monoclonal antibody? Patients who are at high risk, patients who had a positive PCR, and they are not short of breath and they're not in hospital and they're 12 years and older. Although I can tell you, I had a patient who was 8 years old. I contacted the FDA, and within 24 hours, I was approved to give the patient the monoclonal antibody. So, who are the patients who are at high risk? 65 and older, overweight, BMI 25. Everyone I know is BMI 25. I don't know anyone less than 25 unless they're like a model for Vogue or what have you. Pregnant women, I can't overstress pregnancy. Pregnant women, they should get the vaccine. It's really important. They're at high risk. I can't tell you how many times the patient would lose her child. She may end up on a ventilator. And she's young, and it's really sad situation. So these patients, they qualify for monoclonal antibody. They should get the vaccine if these patients, we can catch them early. Diabetes mellitus, type 1 or 2, any immunocompromised disease, anyone who's on immunosuppressive treatment, anyone with heart disease, anyone with COPD, or anyone with sickle cell disease, and smokers, anyone who have a developmental disorder. Yes, the future is good. We have a new treatment coming, and Merck drug is going to be approved in November. There are other companies coming, such as for Roche and Pfizer. They're coming in a month or so, and the trials show that these patients, they have really good success rate, but for mild cases, if we can get them early, we can give them the drug. Molnupiravir, the drug for Merck, which was tried for influenza, it seems it's 50% efficient for COVID-19, but it will be available in November. Stage 2 of the illness. So now we move on where the patient have pneumonia. We need to have confirmation by PCR. Unfortunately, we don't have the culture yet available for commercial. Most people will have symptoms, shortness of breath. These patients will qualify for remdesivir. They'll qualify for steroids if they're short of breath, but they will not qualify for the monoclonal antibody. Now, of these patients, there are certain predictors which can predict the poor prognosis, including being male, increased age, high viral load, other comorbidities, including hypertension, diabetes, and I cannot emphasized obesity. 30, a BMI of 30 and above is really a problem. And if you look around you, I mean, every one of us should have BMI of 30, which is really unfortunate. Coronary artery disease. We can look into D-dimers, we can look for CRP, we can look for ferritin level to tell you who's going to have a higher morbidity, but really look at the patients and their progression and their comorbidities. The next stage, when the patient is really hypoxic, at that time when they need oxygen, they would need anticoagulation, they would need to be on steroid, antibiotic, because we're concerned about co-infection with bacterial infection. But in these stations, we have to look for organ damage, cardiac, kidney, liver, etc. We need to look for hypercoagulability. We have to make sure they don't have pulmonary emboli. So D-dimer will be helpful, but CTA will be very crucial if they're on too much oxygen. And then obviously if they progress to stage 4, which is multi-organ failure, their mortality rate is almost 100% when they get to stage 4. In stage 4, there's endothelial damage, there's thrombosis, there's multiple organ damage. These patients, while they are minority of the patient, get to the stage 4, but once they get to stage 4, there's really little we can offer these patients. There's endothelial infection, there's hypocoagulability at the macro level, and these patients we really have no treatment. There's a lot of theories, there's research. We identified HLA, which can identify these patients who will progress to stage 4, and there are studies going on what drugs to use for these specific inflammatory markers, but this is going to take us a few months. Right now we have tocilizumab, but we have baricitinib, but these patients who qualify, first they need to be on high oxygen, second we need to get them within 24 to 48 hours when they go on high oxygen, and they need to have really elevated markers. We need to have a CRP of 75 and above. Moving on to drugs which showed there's no benefit, hydroxychloroquine, ivermectin, antibiotics. I want to stop on antibiotics. Antibiotics don't work for the virus, but if the patient comes to you and they've been sick for a week or two, and if you talk to the patient, they've been sick for a couple of weeks before we see them, and then the last 2 days they are short of breath. So you wonder if they have superimposed bacterial infection, and that's why we give them antibiotic for 5 days. But you know, antibiotic for the virus, obviously it doesn't work. Ivermectin, I mean, I don't want to really discuss it a lot. It doesn't work on the virus. I mean, it's mainly used for worms. It's mainly have very low concentration in the blood. If you want to use it higher concentration to get to the lungs, then you're looking into toxicity for the liver, etc. And the problem with these, hydroxychloroquine, ivermectin, all this stuff which the people are saying, I mean, you give your patient a false sensation that he's being treated, and he's not, unfortunately. So when you give them this false sensation, they progress slowly on shortness of breath, and by the time they feel really bad, it's just too late for us if they exceed the 10 days window. So you know, remdesivir really doesn't work, and steroid is just too late, and I think you're doing a disservice if you tell your patient take this medication. So that's why we should not, I repeat, we should not prescribe this medication, hydroxychloroquine, ivermectin, antibiotic, and then steroid in patients who are not hypoxic. We don't need to give them steroid. It doesn't really work. Now, yes, there's a role for inhaled steroid for these patients. You can give them that if they're not hypoxic, and it does show it's reduced the symptom duration by 2 days. And obviously colchicine also the same thing. The study shows it really doesn't work. So we should not use this medication for COVID. It's really important we continue all their home medication. It's really important we control their diabetes. It's really important we can use Tylenol. Any medication to make them feel good. For cough, we give them anti-cough medicine. For nausea, we give them nausea medicine. Vitamins, it's really up to you, but what's really important is if they are vitamin D deficiency, then we have to supplement their vitamin. but the rest of the vitamins is really, it doesn't really show. Zinc showed in influenza and upper respiratory infection it may help. If you want to use zinc, then it's really up to you. That's why, so we really don't have a good drug for this virus, but we have the vaccine. The vaccine is amazing. Everyone should be vaccinated. I can tell you in my experience in the third wave, all my patients, 95% in the hospital, they are unvaccinated. 95%, they're all young, they're in the 20s and 30s and 40s, unvaccinated. 99% of my intensive care unit patients, 99% unvaccinated. 1%, they are old, they have COPD, they have heart disease, they have cancer. 1%, that's expected, that's okay. But 99% young, healthy, unvaccinated, we have no treatment and they're all dying, which was really heartbreaking. So please, talk to your patients. And if they're saying they're young and thin and fit, we'll talk about the post-COVID, the long COVID. If you tell them like 30% of patients who are unvaccinated get COVID, they have long disease, a long-term disease, maybe you'll convince them. So coming back, the vaccine is really important. It's a success in this disease. The World Health Organization, we have 19 illness, now there's 20 who is approved. So the vaccine is something really old. And in the World Health Organization, they would approve the vaccine for 50% efficiency. We are talking about 60, 70, 90% efficiency in this virus. So it does work. There's different kind of vaccines. We have inactivated vaccines like the Chinese, live attenuated vaccines, messenger RNA. Messenger RNA, I want to stop. Like the one which we have for Pfizer and Moderna. These are not new vaccine. We had them for 30 years. We've been using it in cancer. We've been using it for other vaccines. It is the future. Most of our vaccine will turn into messenger RNA. And the beauty of messenger RNA, the vaccine doesn't even go into the nucleus. It stays in the cytoplasm. The vaccine, the cells will make the protein, the B cell, the T cell identify it, the natural killer identify it, and then the whole thing disappears in a couple of days, but the immunity lasts for years and years. So it's really, really amazing technology. So the COVID vaccine, which are available now, we have at least 22 vaccines approved by one country in the world by now. 22. 3 approved in the USA, and that's what I'm going to discuss. We have Pfizer, which is approved for 12 years and older, and in November 1st or 2nd there's a meeting, and they're probably going to approve it for 5 years and up. It's a 2-shot, 3 weeks apart. 2 weeks after the second shot, you have immunity. And the beauty of Pfizer and Moderna is really very effective and very efficient. Moderna, again, right now it's only people 18 years old and older, but the studies are coming up for younger. Again, it's 2 shots given 4 weeks apart, and 2 weeks after you have immunity. Johnson & Johnson, initially they approved it for 1 shot, but now they want 2 shots. And it works for 2 weeks after the shot. But the Johnson & Johnson, because it's 1 shot, the immunity is less than the 2 shot. And here's the studies which showed that if we give Moderna, it's 93%. That's very good. World Health Organization approved vaccine for 50%. So 93% is amazing. And the reason why it's slightly higher than Pfizer, because the vaccine contains more mRNA in it, but given the fact it has more mRNA, it has slightly 1 to 2% more side effects. So Moderna have more efficiency, but slightly more high side effects. Pfizer is 88%, 85 to 91%. That was for Alpha. Delta was a little bit less. Johnson & Johnson again was 71%. So you see it's less. That's why we need a second shot for Johnson & Johnson, and the same for AstraZeneca. AstraZeneca is 71%, so we need a second shot. The protection for all these vaccines, there are several studies that showed 4 months, 6 months, and now there's 9 months decline, but it's decline in the level of the IgG. There were studies showed that the B cell inside the lymphocyte, inside the bone marrow, still remember the vaccine, still remember the virus. So even if the IgG subsided, the human body is still immune to it. And that is not to discuss the T cell immunity or the natural killer immunity, which we don't have a test for it, but the universities and the lab which they did the studies is still active. So even though the IgG is dropping, that doesn't mean we don't have immunity. And remember, for hepatitis A, we give 2 shots, and even if there's no IgG, the patient's still immune to hepatitis A. So the protection from these vaccines is positive, and it is at least the theoretical study, at least 12 months, if not more. So all the FDA approved, they have a substantial protection against COVID-19, against hospitalization, and I can tell you from all my patients in the third wave, 95, 96%, they are unimmunized. Okay, so let's talk about the vaccine. Yes, there is, a slight chance of having side effects. So myocarditis, it was discussed for Pfizer. It's 12 cases per 1,000,000. But I want to tell my patients, if these kids get COVID, it's a lot higher than that. And now, since we're seeing an outbreak in COVID in the kids, we are seeing more side effects and we're seeing more ill. Our children's hospital in Houston are full of patients, young kids with COVID, with myocarditis and other illnesses. So while yes, there's myocarditis with the vaccine, number one, the incidence is 12 in a million, while the virus is probably 3 in 1,000, so it's a lot more. And number two, all these cases, they went home with no problems, all of them. And actually, a friend of mine, his kid, they got the vaccine. They were in the hospital for a few days and they went home. So the vaccine does work. The side effects is minimum. It does work. So messenger RNA vaccine. So you give the vaccine, it goes into the cell. It produces the protein, which is the S protein. That's where the immune cell recognizes it. And in a couple of days, all this will go away, will disappear, while the immune response stay for a year or two. So it's really, really important. And it's only about the spike protein, which really that's what we're concerned about. The mutation. Why the virus continues to mutate? We saw alpha, now we have delta, and now we have mu. We're probably going to go through the Greek alphabet while we're done with this virus. But the vaccine does work. Now, it works 95%, 93% in the beginning for alpha. It dropped to 88% for delta. So yes, there's a drop. That's why we encourage the third shot to push the immune system from the 80s to the 90s. But the vaccine still works, is still effective. And the UK is the leading because they're the one who first have the delta. They have beta and then delta. And their study shows Israel is also the leading. Their hospitalized rate is extremely low, even though with the Delta variant. The Delta variant, so the virus continue to mutate, and the one virus which can infect human the most, that's the virus mutation which can see the most. We'll start one country with the travel nowadays, international travels. It may appear in one country in a few days. We'll see it all over the countries. And we still have outbreak here and there, and Indonesia, there was an outbreak of a new variant, but that disappeared. There's a South American, there's also in South Africa. But the vaccine is still working against all these so far. So it's really important to push the vaccine. Now, all the studies which led by Israel and the UK, they showed the vaccines continue to work. Johnson & Johnson vaccine, which use a a virus to carry the antigen, the spike antigen. It's the virus which is like a Trojan horse. The virus is very benign, and they initially seeked for one shot, and they wanted to do that so they will be available for as many people as possible. It's very efficient, it's very effective, but only 60%. That's why we ask patients if they get Johnson & Johnson to get a second shot, preferably Pfizer or Moderna. Now people will ask me about how about the Chinese, how about the Russian, how about all these other vaccines was coming. I would recommend 2 shots. I would recommend to get any vaccine is available. Any vaccine is better than having the disease, no doubt. Johnson & Johnson efficacy, as I said, is 60%. We had some problems with thromboembolism, with ITP, which I've seen. I also seen Guillain-Barré, but again, comparing this to the disease is really nothing. If you get 6 cases in a million, the disease you'll have 3 in 1,000. So you can see it's really important to get the vaccine. In the beginning, Johnson & Johnson was efficacious for 71%, and then with Delta it was 61%. That's why we recommend the second shot. But the long-term efficacy of the vaccine is clear. Even though the IgG level drop in the blood, like I said, and it dropped from the 90th% to the 70th percentile, a booster will pump this to the 90th percentile again, especially in people who are like 65 and older. We'll talk about who needs to get a third shot in a minute. The beauty of the vaccine, it doesn't only help the patient who are vaccinated in terms that they will get less pneumonia, they will get less intensive care, their mortality improve, but they also help the transmission. And in this one study in which they compare people who work in the healthcare and we gave them the vaccine versus people who work in the healthcare and they did not get the vaccine, there was a 60% reduction in transmission. 60%. So the vaccine not only helps people who are getting it, but also protects your family. So that's why it's important to get the vaccine. Moving on, who gets the third shot? Okay, so because we had a third wave, because we had high circulation in the community of COVID, we're recommending a third shot. And with the Delta wave, it's as we saw, there's a reduction by 10%. So we need to push our immunity 10% higher, from 70 or 80 to 90 percentile. So who gets the third shot? 65 and older, 18 years who lived in long-term facility because they have high circulation, 18 years who have any medical condition which compromise them, like diabetes, high blood pressure, cancer, COPD, etc., obesity, a smoker, and also people who work in high-risk settings, so like doctors, people who work in hospitals, people who work in nursing home, and then people who live in high-risk setting. So who is at risk for severe illness? So in these people, we should, stress out they get the third shot of the vaccine. They're the one, if they get sick, we give them the monoclonal antibody. If we get them early. Pregnancy, I cannot really emphasize how pregnancy is really important. I have several young patients, 20s and 30s, they're pregnant, unvaccinated, they get COVID, and it's really sad because one patient, she lost a baby, another patient we had to intubate her. We can save some, but it's really sad. Substance abuse is another problem. Asthma, high blood pressure, cancer, CVA, COPD, chronic kidney disease, cystic fibrosis, diabetes, Down syndrome is really important. Any neurological disorder, obesity, so 25, BMI 25. I think we are all obese according to 25 and high, and then smoking. So now I move on to the long COVID. That's one discussion you can have with your young patient who are like athletic and they don't want to get the vaccine. You can tell them, listen, 30% of patients who get COVID have long COVID. What is long COVID? So long COVID is a new entity which we are recognizing. It happens 4 weeks or after or more after the illness. And people, which is interesting, they may not have COVID symptoms, but they have IgG and IgM, and then 4 weeks later they have to have symptoms. So these patients are really interesting, and you should talk to your young patient. They should get the vaccine. And the problem with this long COVID, as we're going to see, it can last 4 weeks, 8 weeks, a couple more months. And in one study, it shows 30% of patients have shortness of breath without destruction to the lungs. So you get a CAT scan, there's no pulmonary infiltrates, but there's short of breath, there's fatigue. Some of them have headaches, some of them have mental problems, some of them have cough. The worst case I have seen a young lady just yesterday. She had COVID 6 weeks ago, and she cannot walk. And we did an MRI. There was nothing. We did a spinal tap. There was not. I thought she had Guillain-Barré, but all the studies showed she doesn't have Guillain-Barré. She just has neuropathy, and so now she's using a walker. Yes, this is rare. Yes, it's very unusual. We should probably write it up, but it's something to discuss with your patient. There's cough, there's headache. I have seen a lot of joint problem. I have seen some diarrhea, some sleep disorder, some fever on and off, rash occasionally, mood changes. So it lasts for 4 weeks. There's no treatment. Mainly supportive. We can tell the patients, I'm really sorry. Remember the chronic fatigue syndrome, which we see with the viral illness, is the same. We're going to see more of it now with the COVID-19. And it's 17%, which is like to 72% in some studies. So it's very significant. And these patients who are hospitalized, they have 85% if they're hospitalized. So, that puts them at risk. People who have comorbidities. I have patients who lost their smell for a while, and they still, a few weeks later, I tell them to use nasal steroid. It may help for 2 weeks. So post-COVID is a true problem which we're going to deal with. And these patients who have a pre-existing comorbidities, hypertension, diabetes, obesity, these are the ones who have more problem than the rest. You can tell them, the good news, they have good prognosis, there's no further complication, it's just an annoying illness, they're going to live for a while, but it's not lethal. So to summarize, it's really important to push the vaccine. I cannot tell you how important it is, and now we're open for questions.